Morning, everybody. I told Yui that I'm not a big fan of introductions. I apologize. It's a pleasure to speak to you today. I used to, up until July of this year, run an adult congenital heart disease program between the Brigham and Women's Hospital and Boston Children's Hospital. I'm a native New Yorker. Came to Boston a little over 35 years ago for medical school and stayed there. I'm the incredibly proud parent of 3 kids, now 5 kids, 2 of them married, 2 grandkids. My bride is the best doc that I've ever met. She's the best LANDZBERG doc. I've got 1 kid who's a doc, and a whole wonderful mess of trainees that have come out of our program and have gone around the world leading adult congenital heart disease programs. Dr. Lin was kind enough to ask me to speak to you about our love of congenital heart disease. And I have to tell you, I was a bit stumped in terms of what to speak about because you have a lot of great scientists who have spoken to you about pathophysiology, physiology, the next step in terms of our understanding of concepts that are going to rock the world. And I could do that in part. I was told when I arrived in Boston that part of what I needed to do was to help create a platform, let others with us develop a science to our field. And there is a science to our field. We'll talk a little bit about that. The talk's going to be a little bit different than that because I'd like you to take something away that's different from other grand rounds that you've had. And the title of this talk is called The Space Between. Reference, this is going to be a little bit of back and forth between us. The space between. Anybody have any concept of where that title comes from? You can wake yourself up. It can be from anywhere. Feel free. Where have you heard the space between before? It's not rhetorical. Biblical concepts, people talk about the space between, that sacred space between. If you go back to the Holy Covenant of the Ark, this is Methodist hospital, I'm told, that there is that space between, which was where the Creator sort of existed between the 2 angels and the like. No, that's not necessarily what the discussion is going to be about. I told one of our fellows the title of the talk, and they got it. He said, Dave Matthews. And I said, absolutely. And you're going to see here one of 2 tattoos that I will share to you from our patients over the course of this talk. From the 2001 album by Dave Matthews. Dave Matthews, by the way, transformational for me in terms of how I see music in the world. That being said, this was embroidered on the arm of one of my patients. The space between the tears we cry is the laughter that keeps us coming back for more. Poignant. I mean, it takes a lot to tattoo a quote on your arm for you to see this. This was the humanity that this young patient had come to recognize early, the relative suffering that she had gone through in order to have that sacred space of whether it was happiness or meaning or the like. Before we get to the rest of the talk, let me share a little bit more. My middle name is Job. I don't know about the rest of you in terms of your middle names. It's a little bit unusual up north in terms of having the middle name Job. My parents decided to lay me with something that would sort of last with me. Boy named Sue, boy named Job. Okay, that was me. How many of you are familiar with the story of Job? Wow. I am not going to call on you to tell the story. My interpretation, because I've lived with the name, is a little different. And let me share with you a little bit of that, if that's okay, the story of Job according to LANDZBERG, and tell you why this applies here as well. These pictures are taken, you folks may know the poet William Blake, 1800s, 19th century British poet, was also an engraver. These are engravings from the book of Job by William Blake to help me. William Blake had foreseen that I would be speaking to you all. Open up the story of Job. Job is on the earth. Job is a good man. Job is seen here in this picture in front of you. as incredibly successful, great wife, great kids, great fields, great animals and cattle. He is admired by his entire community and admired by the entirety of the earth. And there he is on the earthly plane, the Creator up high, hanging out with his angels. The number 2 angel, interesting, in this story in the Bible, the Creator looks down at his number 2 person, who is Beelzebub, Baal Zevuv, in Hebrew, Baal, Lord, Zevuv, the flies, Lord of the flies, the devil, looks down at the devil and says, my man Job, good man, huh? And Job says, well, the devil says, not really. You've been kind of good to him. You give him all the great things that any human being could possibly want. And he says, thanks for that, but if you hadn't given him all that, he wouldn't necessarily be this real good kind of guy. And the Creator says, well, actually, you're wrong. And then this weird view of the Creator in the story of the Bible is that the Creator says, well, why don't you start taking stuff away and I'll make you bet. A betting Creator. And the devil says, you're on. And so what happens? Step 1, the devil looks down, sees the prized possessions of Job, his children. His children are having a party in a house. The devil takes the walls of the house and kills all of the children by collapsing the walls, all except one. One comes back and runs to Job and says, all of your kids are no longer. And Job the pious, Job the good, takes it in. His world is not rocked sufficiently to challenge his meaning. Looks up to the Creator and says, thank you, Creator. Thank you. Devil chagrined. Devil decides, okay, I will kill all your cattle. Job looks up to the Creator and says, thank you, God, love you, God. Destroys his fields. Thank you, Creator, thank you. Then at one point, the devil's exasperated and gives what the Bible says is terrible human suffering to Job. Bicuspid aortic valve disease, truncus arteriosus, transposition of the great arteries, pulmonary vascular disease, something. Some congenital thing that Job has to live with. I'm just making an analogy. The Bible doesn't say that. And it's interesting because Job says, thank you, God, love you, Creator. But he reaches out and he says, but why? My world and my assessment of this, bad things don't happen to good people. You know, I've been a good person here. I don't get this. I don't understand this. And the retort from the Creator is really interesting. Because whether, if you're Christian, it's the books and the pages that you turn, and in Judaism, it's the scrolls you turn. For page upon page, scroll of turning after scroll of turning, the Creator lambasts Job and says, like, who are you to ask me why? Where were you when I put order into the universe, when I created this, created that? Where were you? Why are you asking me about the meaning of the universe? Job just sort of sits there and goes, whoa. It's quite interesting because Job looks to the Creator, and after all of this, after the Creator sort of explodes in this, where were you? Why are you? Job goes, okay, I assent. I get it. My concept of the meaning of the world, I still must have meaning in the world. I don't understand, but I'm going to hold to what I have kept as my meaning. And it's interesting, Creator rewards Job for that, gives Job back. I don't know how you can give back kids. Give Job kids times 3, fields times 20, animals times 1,000,000, and Job becomes a successful sort of guy again. And it's interesting, in the picture from Blake, here you have at the very end, Job up high, approaching the heavens. This was Job in the beginning, down low. Job up high again. Job attaining some greater level. It's interesting, in the Bible, the people that have questioned the Creator, kept to their meaning, but questioned the reality of the world and questioned things, are those that got rewarded throughout the Bible, whether it was Moses before he entered the Promised Land, Jesus in terms of questioning the Creator. People do question and get rewarded. But it's holding to that meaning that we're going to speak about over the course of the space between. I'd like to speak to you about a bunch of patients, and over the course of about a half an hour, we'll talk about 6 or 7 patients, go through some concepts of meaning, and make this a very personal approach to care of adults with congenital heart disease as a model for lifelong disease, chronic disease, and what we as cardiologists aren't necessarily used to in terms of our care motifs. Patient number 1, this is 1992. I'm a young cardiologist between Boston Children's Hospital and the Brigham and Women's Hospital. And like this morning, we had a medical surgical conference, and like this morning, we sit around at a table. If you see in 1992, there weren't a lot of women around that table. And there I was presenting some patients at that time. And it's interesting because our world was that based upon, as we did this morning, the anatomic and physiologic determinants of outcome. Presenting patients, having us as cardiologists and as surgeons debating whether we should do something. This was a patient with tetralogy of Fallot pulmonary atresia. I'm not here to teach you about tetralogy of Fallot pulmonary atresia. The basic concept, pulmonary atresia, no flow to the pulmonary arteries from the nascent, the beginning right ventricle. If you look on the schema there on the left, you'll see that there's no outflow. The lungs were not perfused. The lungs didn't grow normally. So blue blood from the right ventricle went across into the left ventricle, purple circulation out to the body, and then blood somehow magically made its way to the pulmonary arteries from this dual circulation that lives the equivalent of bronchial collaterals, the bronchial circulation off the aorta. And this patient was living off bronchial collaterals. The modus operandi in tetralogy of Fallot pulmonary atresia is whether or not you can create a tree of the lungs, whether you can sort through the pulmonary vasculature, understand resistance, understand capacitance. It's a beautiful model of physiology in terms of ventricular arterial coupling and what really determines afterload. And this is how I learned cardiovascular physiology in the 1980s and 1990s. And so the goal was to take these blood vessels and in some staged fashion begin to incorporate these branches of lung tissue. Imagine, watching my arms here, imagine the branches of a tree that are coming off the aorta, not the pulmonary artery, and having to separate them off the aorta, bring them in some new tube or conduit, and attach that to the right ventricle. Create a tree of the lungs. That's what our goal was going to be, and that's what the typical sort of operation would have been. So there we were with this goal. The problem is that life had gotten in the way for my patient. We had gone through these first stages of beginning to collect these pulmonary arteries, what we would call unifocalization, the term that we use in terms of bringing together arteries, getting some control of them from the front, from the side, bringing them together so that ultimately we could create the tree. And what got in the way for my patient was her divorce, her depression, and instead of the standard at that time of going in 6 months, 8 months, from one step to the next step to the next step was suddenly 4 years later, and I had left her over-circulated. All the blue blood was entering into the left ventricle. This was an increasingly volume-loaded ventricle. And there I was at Med-Surg conference, that's me without the gray, a younger Mike LANDZBERG presenting. And I have to tell you, sitting in the front row were my mentors who just took me down and created a new portion of my body or hole in my body, which we won't get into the specifics, but I was taken down a step, and the answer was, why didn't you? This should have happened 24 months ago, 36 months ago. Why didn't you do this? And this, you want to get up and say the patient had her divorce, had her depression, you need to enlist and enroll the patient in care. And the statement was, this is a world of pediatrics. We don't do, it's moving forward. You move forward, you work with those parents, you get them to move forward. That is your obligation. There was this incredible pediatric cardiologist who just sat on my shoulder. She was about that tall. Stella Van Prague, there's a Van Prague classification of understanding anatomy with a great pathologist, her husband, and Stella, this petite but brilliant cardiologist, looks over my shoulder and says to me, Mike, it's okay. Folks in the front row have their job to do. You're taking care of the patient. The success for your patient is going to happen if and when you take that patient into consideration. Had you moved forward 3 years ago, life would have fallen apart. We would have done a great surgery, but she didn't have the supports in place to get through what she needed to get through. Glad you did that. And you were watching every 2 months, every 4 months. You made sure that happened. Made me feel a little bit better. Patient number 2. There's a method to the madness of the patient succession that we talk about. Folks with me okay so far? Yeah? Nods? Okay. Echoes. Classic echo for somebody with right ventricular hypertension, pulmonary arterial hypertension. In long axis, that's the right ventricle on the left there, muscle bound at its apex, left ventricle, the smaller ventricle in this circumstance on screen right. Patient with dilated right ventricle, pulmonary arterial hypertension. In the short axis view, you see this right ventricle just sitting on top of the left ventricle below it. Lisa was a young 30-year-old with idiopathic pulmonary arterial hypertension. And it's part of our work in Boston. We were both PAH, or pulmonary hypertension at the time, primary pulmonary hypertension, what we called it. And at the time, in the early 1990s, we had nifedipine as a therapy for the 10-20% of people that responded, and then soon thereafter, we had intravenous prostanoids. At the time, Flolan, epoprostenol. Folks familiar with these therapies? You betcha. So Lisa was taking intravenous Flolan, and she had a remarkable turnaround. Just this remark, she went from being totally dysfunctional, as many of folks did. 90% of people get 90% of their goal if you give them intravenous prostanoids. It's a good drug. Lisa came in to a hospital with multiple bouts of syncope, was failing. Her world over the last visit, highly functional, nearly class 1, had become class 4 with no good, clear medical precipitant. We didn't have bailout therapies. I didn't have ECMO at the time in Boston for her. I did not have transplantation for her. What we had for her at that time was trying to unload the right ventricle, which, as you see here on the picture, it makes sense, right? If you can't get the blood out to the lungs, you're familiar with this concept here. It's not necessarily what we would choose to do necessarily today. We unload at the atrial level. If you have both systolic, diastolic failure, you can allow blood to go from the right atrium to the left side of the heart. This statement, better to have a blue cardiac output than to have no cardiac output at all. And so we did an atrial septostomy, Lisa got better. That's not the message that I want to leave you with. We do the procedure, Lisa slowly gets better, and she says to me, by the way, I guess I should have told you something. And I go, yeah, like what? She goes, I tried so hard, but I missed him. And I said, at least I don't follow. And she goes, pardon my language here, my husband, that son of a that husband that used to be my husband, the day before I came in, I was actually doing fine up until 2 days before. My husband turns out had been cheating on me, and that wasn't the big deal. My husband had gone into our bank accounts and had cleaned out our bank accounts, and so that all the money that I'd saved up for our kids was no longer there. So what I did is I reached out to the butcher knife and I waited for him to come home. And the only thing I regret is that I missed him. I said, Lisa, you know, I'm there with you. Would have been nice had you told me that, because I probably would have just sort of put you to rest in the hospital for a week or two, taken you out of the environment that you were in and let things sort of calm down, because there is, just like with asthma, there is this medical in the brain and medical in the body sort of overlap. Would have been good to know, because there really are non-cardiovascular, non-medical occurrences that determine outcomes. And so I took that with me. There is a science to atrial septostomy. There is. I'm glad we did it, maybe. Might have had the same outcome, interventional cardiologist, I admit. Might have had the same outcome had I just given her bed rest or rest in the hospital or taken her out of her social environment. Ready for third patient, is that okay? Not too touchy-feely, California-ish, is that all right? Okay. Yeah, this one's tough. Forgive the next picture. This will be my disclaimer. This is Bob. Bob wore this. Bob was a patient of mine. This is how Bob grew up. Bob had tremendous facial dysmorphism. Horrific. Was born with so grotesque and distorted a face that he couldn't speak or grunted. That was how he was able to communicate. Bob had tetralogy of flow, not with pulmonary atresia, tetralogy of flow, something relatively easy to fix. Bob, because he was felt to be intellectually incapacitated, he could only grunt. Bob was housed, if you will, in, Tom, you may remember the Fernald School. It's the first in the country state institution for, well, what was the expression here? The Experimental School for Teaching and Training Idiotic Children. That was on the books. That was the name of it. Yeah. Non-PC, the president would have said that was okay. The Fernald School is interesting, founded in the mid-1800s. You'd think on the outside that the state institutions do good. We all are aware of the many 1960s and 1970s beginnings to demonstrate that no matter what the intentions are, it isn't always that way. The Fernald School was riddled by folks that led the Fernald School who believed in eugenics. You're familiar with eugenics, the concept that race and other aspects of our body make us more sound as human beings. What's particularly interesting, you see that third line, 50% of the residents at Fernald had normal IQs. So that folks were housed there if they were poor. Folks were housed there if eugenically they were felt that they were not appropriate to be living in society. And our own institutions have plenty to make us think that we're not proud of. Harvard, MIT did lots of experiments on kids at the Fernald School. Bob grew up at the Fernald School. Bob beautifully, at the age of 18, had a visiting orthopedist and plastic surgeon come and say, I think we can work on this face of yours, and in fact did, and suddenly Bob was able to speak and to speak normally. Bob went on to the University of Massachusetts, where he was valedictorian at the University of Massachusetts. Fernald School, grunting, to the University of Massachusetts, Boston campus, valedictorian, where in his valedictory speech, he said, no one tried to listen to me, but now I finally have a voice. I must tell you, yes, we faced pulmonary valve replacement issues of melody valves and percutaneous versus surgical valve. I'm not talking about that today. There's a science to that. This is Bob saying to us, I was able to speak. No one tried to understand me, to understand the patient. First patient through her divorce and her depression. Second patient in terms of listening to the patient. Third patient, no one could hear me. There's more. Each one taking us down a line that we'll get to. Barry Keene was a medical cardiologist at Boston Children's Hospital. The field of pediatric cardiology began with a lot of internal medicine cardiologists who transitioned into the pediatric world to add that expertise into a growing field. Barry was a catheterizer. Barry was head of the ICU. Barry was a remarkable internal medicine and pediatric doctor who said to me, Mike, I have a patient I'd like to transition or transfer to you. I said, sure, Barry. And he said, well, it's an interesting story because I need to tell you why I want to transition this patient to your care. I said, sure, Barry. He said, let me show you a picture. I said, okay. He said, the picture had the crown of thorns, again, the Methodist sort of motif here, the crown of thorns that sort of Jesus wore sitting on the head of Dr. Keeney. He had drawn this incredible picture of his cardiologist, lifelike, with a crown of thorns, but it wasn't just a sort of nice crown of thorns. We're talking the crown of thorns had these drops of blood coming down over Barry's face, and Barry said, whatever this means, it's more than I can handle. I think I need to transfer my patient's care to you. I said, okay, great. He said, there's something, though, I should tell you. I said, there's more? He said, yeah. He said, the patient's mute. I go, okay. He said, well, the patient's volitionally mute. He was able to speak up until he was about 5 years old. His disease is bicuspid aortic valve. You don't have to worry about his particular disease. Now, that's not necessarily true. Bicuspid aortic valve has issues with the ascending aorta over time. That's not what we're here to talk about. Patient was volitionally mute. I thought, okay, great. First patient visit, I go to see this young man, and I walk into the office. You expect, you got the chart in front of you, you're boned up on the chart. Patient's standing there in that position. This is the position. I walk into the office. Patient's just standing there like this. And I'd ask you all what your technique would be to try to bond with this patient. And I have to tell you, I sat there, thought about it, and I said, okay, got my machismo up a little bit, so I decided I'm gonna join him. So I just sort of stand there in the pose, and I'll tell you, I'm not that agile, and I didn't keep it up for a long time. I'm standing there. That didn't break the ice. I tried. It did not work. Sit back down, and I say, so the chart here says you're mute. Don't get anything. I said, volitionally mute. Don't get anything. And I said, so can you talk? And he says, yeah, sure. And I fall backwards because the chart had said volition. It's for 20 years. The chart said volitionally mute, no history from the patient, no nothing. And it's almost comical because I said, but you haven't talked in like 20 years, and this was a statement back. But for the past 25 years, nobody's ever asked me. And I said, come on, no. And he goes, no, honest to God. If you ever saw One Flew Over the Cuckoo's Nest, the chief has that same response. And I thought maybe he'd watched the movie and he was waiting to use the line on me. But it was true. I went to all of his care providers. I said, did you? They said, no, I got busy, didn't think about that. Nobody had ever asked me. Last one or two about communication, because I'm using up time. This is a patient of mine, but a patient I mentioned to you when I first began that my wife is the best of the Landsberg docs. This is a patient I shared with my wife. Patient had truncus arteriosus. Let's start it that way. Not in the emergency department. That's a Boston way of calling emergency rooms. This is a 35-year-old with truncus. We're not going to talk about truncus. Truncus arteriosus is a disease of the two great arteries. You know, the truncus arteriosus is that spiraling aorta and pulmonary artery that come down with where my elbows are to meet the right ventricle and the left ventricle. And when that doesn't septate normally, you have one single great artery coming off, and you have to figure out how do you get the pulmonary artery and the aorta to be separated. It's a complex conotruncal defect. We're not talking about that. We're talking about this well-repaired 35-year-old who came from the UK to Boston for his business and his work. And he landed in my office, and he didn't speak about pulmonary vascular issues, arrhythmic issues. It was his erectile dysfunction that he had. And I came to recognize that there was probably an endocrinologic issue that was contributing to that. My wife, the endocrinologist, got the immediate consult from me. And so the patient went into my wife's office. And my wife said to him to put this on. Dr. McGilver, can I ask you, I'm sorry to call on you on this one. In Boston, what do we call this? Johnny. A Johnny. Do we call this a Johnny down here? You do? Gown. Most people call it a gown. It's the New England Johnny, a John. Tom, I apologize for calling on you. Sorry about that. So my wife says to him, sir, you're going to have to put on a Johnny. Patient came from the UK. My wife says, you're going to have to put on a Johnny for his erectile dysfunction. We're going to have to examine you. And I'm not going to mimic a London accent. The poor fellow says, no. my wife says, you're going to have to put on a Johnny. I need to examine you. And he goes, no, I can't. And it's almost like Abbott and Costello. It goes back and forth, and 15 times you got to put the Johnny in. No, I can't. That's why I'm here. No, I can't. That's why we have to put it on. Until finally my wife says to him, we clearly are speaking different worlds and different languages. Because, as you know, in a Johnny in the UK, a Johnny is a condom. And the guy says, I'm here because, in fact, I can't put on a Johnny. It's just not what it is. And my wife totally blushes because I wouldn't have. I have no frontal lobe, but my wife does. And so this statement of listening and hearing and communicating well with our patients is this first 5 or 6 stories that I tell you in terms of the art of what we do, because the science is everybody in this room. I don't doubt this is why we're here. This is why we do it. We do the physiology and the outcomes and the tracking of that. We are the best that we can be at the bedside, but part of that best that we can be is this art of communication that gives us really this foundational understanding between patient and clinician of what the expectations they have of us and what our obligations are back to them and vice versa. I will leave this patient portion with a 6th and final patient, and then we'll talk a little bit about some other aspects of where I'm heading with this. This is an 18-year-old man who dropped the F-bomb on me. This man had 2 significant life-threatening diseases, sickle cell disease with many, many chest crises. And despite our improvement of care for sickle cell, chest crises still carry with them a real morbidity and mortality. He had been intubated multiple times in the ICUs in terms of dealing with his lungs. And by the way, he also had severe subaortic obstruction, muscular obstruction, long tunnel obstruction, one of these recurrent diseases. Had 3 prior operations before. And I was getting to meet him in his first or second visit with me, and he had significant outflow tract gradient. Had come out of the ICU twice in the past. His high end diastolic pressures had confounded the ICU docs in terms of was his lung infiltrates, were they due to end diastolic pressure, diastolic failure, if you will, versus lung crises that he was having from his sickle cell. And I said to him, Joe, I think we're going to need to go back to the operating room. You should make plans to go back to the operating room. Let's book you for about 3 months from now. And I said, you know, everything has reached a perfect storm. We're going to go back in. 4th operation. He said, in all deference, in all respect, Mike, go by first names, Mike, F you. I go, excuse me? He goes, you heard me, screw you. I go, pardon me? He said, listen, I was told with sickle cell that I would never survive. I've had bad chest crises. And I was told that with my subaortic stenosis, where I had my first operation at age 2, and then at age 7, now I'm back again. I was told from both of these diseases I would never, all the would nevers, I would never make it through high school. I would never make it to be a dad. He goes, look, I am a junior in college. I'm about to graduate in a little over a year and a half. He goes, that's about a 100% likelihood if I don't go to have an operation now. That was a 0% for me before. And if I go have an operation now, the likelihood I'm going to go back to school right away and graduate, he goes, I have no idea. So win in terms of staying in school, win in terms of finishing up. He goes, you know, this business about me never meeting somebody, I've got a partner in my life that I'm thinking about spending the rest of my life with. I was never, 0 was going to happen to me. This partner has no idea about what it's really like to go through cardiac surgery, and I'm placing that at risk now. This first 6 months of a relationship, real potential 100% that I have a partner in my life versus if I go through a surgery now, that could be a 0 for me. And by the way, I've got this internship set up with Amazon or whatever it was he was telling me, you know, for the summertime. I would never have a job, but now I'm going to be able to. Nobody in my family has been successful, gone to college, had a job like this. And all those 0% likelihoods are going to happen to me now. And you're telling me I've got a 3-4% risk of dying over the next year because of my subaortic stenosis, yabba dabba doo? He goes, no, pardon me, F you, no. No. What's important to me? You all don't know this fellow. This is Balfour Mount. Dr. Mount was a urologist up in the University of Toronto, the father in North America of palliative care. And I think you all think of palliative care as the art of taking care of the needs of the patient before they die. I would beg to differ. Palliative care has to do with the physical and the emotional and the spiritual needs of a patient over the course of a lifetime, and addressing and understanding those in terms of the care that we provide as care providers over that lifetime. For the patient, it's an active process. That patient needs to understand who they are, what they want, and we have to be part of that process with them. It involves making sure your patient understands what? The disease course, prognosis, influences, therapeutics. Not so easy in a world that's changing, and when prognoses are changing and our therapeutics are changing in our current world. You could ask our parents who were physicians before us, they'd say the same thing, I think even more so now in terms of our advent of therapies. And it involves a constant reflection on the part of the clinician. And most of us would say, I'm sorry, that sounds all great, get the psychologist in, get the social worker in. That's just not the nature of my typical practice. Take a step back with me. The palliative care docs have this expression when they walk into the room of a patient. They say, I'm going to be touching on some subjects with you. Let me open up this box. You're allowed to close it. It may be real difficult for us to deal with this, but what comes out of that box may be an awful lot of things that are just hard for us to discuss today. You close it any time. So I'm going to say to us in this room, if I bring up some subjects, you close them if I keep pushing us a little further than we want to go. Congenital heart disease, at present, is a lifelong disease. We have no cure. We don't. Sorry, we don't. And it's this incredible model of heart failure, this incredible model of pulmonary vascular disease over a lifetime, and the outcomes are changing. The population statistics that we have data. They don't address the individual patient's risk. I'm sorry, no matter what I have in terms of data, that patient's unique. That 18-year-old with sickle cell and sub-AS, his unique risks are different than what I would know from a manuscript about LV outflow tract obstruction. There's huge uncertainties, and the answer is our patients really do experience at age 18, 20, 25, 30, a morbidity and mortality that no 18 through 30-year-old should have to deal with, or 40-year-old, or 60-year-old. And the foundation of our partnership with our patients is to be able to guide them through those spaces between, to make them live well for those periods of time between the medical crises. I'm going to review the world in 5 minutes of congenital heart disease, give you the overview. Anne-Marie Valenti, did she speak at these rounds? So Anne-Marie spoke to you from our group in terms of natural history of certain types of congenital heart disease. That's not what I'm here for. I'm going to give you the big phenotype, if you will, of congenital heart disease in the adult. Go back in time with me to the 1980s, the late 1980s, when I entered into this practice. This is point prevalence, if you will, not really point over a course of a year. What was mortality over the spectrum? The dots are the Quebec population. Turn on the side in terms of reading this. You're going to have to turn your head. It's an interesting way to display data. Take a cadre of patients every 4 to 5 years and look at when are deaths occurring across a spectrum of congenital heart disease in a province where we capture all of the data. And you see the dotted line, the normal population in Quebec. The bars are patients with congenital heart disease. Mortality, when are patients dying? They're dying in their youthful years. They're dying as kids. And we see a lot less death in the senior years because patients aren't making it to their senior years. Jump ahead some 25 years or so, and we get 2004 to 2005, and you might applaud yourself and say, wow, okay, the dotted lines are the normal population, and it looks like we're approximating that. Yeah, there's a little wing of increased mortality in youth there, but we're looking pretty good. The problem is I haven't shown you the middle gap of years. I'm showing you one moment in time. There is this huge pushing of this group here. I'm sorry for the folks on camera. This group here in the beginning in their youthful years are making their way to their senior years, and that mortality is about to happen. The concept, Martin Luther King, when he had his speech on hunger in 1963, the I Have a Dream speech. Before he went to the I Have a Dream, talked about the obligation that we had to, as a country, to the underserved, and that we had promised them in the Constitution, we had promised them in the Bill of Rights, all these freedoms, but it was a check that we had given to folks that had insufficient funds, that wasn't a real check. For adults with congenital heart disease, we've created a population of patients, and we've told them life is going to be better for you. The problem is those middle years comes with a check of hopes and aspirations that isn't able to be cashed, because in fact, that population is ripe with increasing mortality. These are just two diseases. In congenital heart disease, we have three-letter acronyms for a whole coarctation of the aorta, tetralogy of Fallot, hypoplastic left heart. These are our moderate to severe types of diseases. And you'll see a natural history curve here where there is a certain slope during pediatric years and a secondary slope of increasing mortality from age 15, 18, 25 onward. And the reason for that worsening mortality is because of the progressive heart failure, arrhythmias, vascular disease, and other organ system disease that our patients face. It's about being an internist for half of this and dealing with heart failurologists for the vast majority of our patients. If you look at the determinants of mortality for our patients, in aggregate, the more complex the disease, the worse the ventricular function, worse the patient feels, the patient's going to do less well. Our patients are a model of heart failure. This is a pictorial representation. There isn't a patient with congenital heart disease that doesn't have a measurable or definable aspect of heart failure. Interesting. There isn't a patient with congenital heart disease in their adult years that doesn't have an abnormal natriuretic peptide, an abnormal performance score, an abnormal something that shows us myocardium at risk or myocardium at dysfunction. What a model for heart failure over the decades. The more heart failure you have, the more likely you are to die. Your performance, there's nobody, this is MVO2s on CPETs, patients with the mildest of anatomic disease to the most severe underperform compared to that red dotted line of normalcy. Patients have more atrial arrhythmias. They have atrial arrhythmias earlier in life. Those atrial arrhythmias give them a worse prognosis. And the important statement here is that our patients behave with morbidity and mortality as if they're 20 to 30 years older on their insides than their stated age. No surprise that that 18-year-old says, no, I don't know where my future is going to lead. I've got a lot of risk inside of me. I may look 18, I may perform to some folks as well as I should, but my mortality is real and I've had to face that over time. These are just increasing morbidities that our patients have had. The morbidities are not trivial, and let me have you take some of this away. Even if it's not something that you see on the medical inside of what we're used to dealing with, give me 5 seconds on each of these, 30 seconds on each of these, to show you that the cognitive executive function of our patients is often highly abnormal. This is a basic figure that is used by psychologists to understand executive function and ability, spatial recognition for kids and adults. You give them a picture, you tell them, go ahead, try to reproduce that picture. You can have that picture in front of you, you don't have to memorize it. And the typical, second grader can give you a picture of something like that. That's not bad. For me, that wouldn't have been bad, right? Here's a patient with transposition in the second grade compared to the normal kid. Spatial recognition, way off. Move that up to somebody in their adolescent and adult years. I don't know if any of you have done this. There's this theory of the mind, which is some of the shrinks will use sometimes to get an idea of our executive function, is used in executive function assessment. You take a face, you just show this portion of the face, and you ask somebody, tell me what that person feels. This is a critical aspect of how we interact with people, right? You have to be able to read the environment. Most of us would look at this, you'd have to make a choice. I'm not going to ask you, because we're all going to see it a little different, right? We're all different. But most of us would say this is somebody who's despondent, somebody who's sad based upon, I'll show it to you again, here you go, yeah. Probably. You take a bunch of some 35 faces like that, you're going to get a display, but the vast majority of people are going to nail it 25, 28 out of the 35 times. Take somebody with congenital heart disease in their adolescent to young adult years. On average, folks with transposition of the great arteries, folks with tetralogy of flow, been through operation. There's something more. There's something different here. This isn't the cardiopulmonary bypass run necessarily. This isn't the pump head. There may be real processing issues that our patients have that are born with. This may be the baggage that our patients come with and have to deal with as well. The phenotype of our patients is one of real morbidity in terms of understanding who they are and where they want to go. And our patients can feel trapped. And that's the reality. And they do feel trapped. And it's this bond between the physician and the patient that I will argue that helps us get out of that trap. How do people deal with the inevitable? We all have our way of dealing with it. It's quite interesting. This is social theory. We cope and we swing, all of us do, between the realities of what is known and our optimism. It's somewhere we pick and choose, and we do this all the time over the course of a day, over the course of a week. We swing to allow ourselves to cope with that unknown. I want to deal with this last patient and potentially quit there just in terms of time. I have a whole additional portion that we could go to, and maybe we'll take some of that in questions. But this is patient number 7. And perhaps let me leave you with patient number 7. Patient number 7 is a 28-year-old who comes to our practice from New Hampshire. He is a highly functioning CEO of a startup. He has 2 brothers, had 2 brothers, one of whom died from drug overdose, heroin epidemic. The other one is in prison selling heroin. And I said to him, dude, you got Epstein disease, you're coming in for your second operation for your tricuspid valve, something that my colleagues, Tom and colleagues at Mass General had perfected before we had across town at Boston Children's and at the Brigham in terms of operative therapies. I said, how do you do it? You've got a family that's in disarray. You're CEO of a startup company. He took his shirt off, and this is the second tattoo. I don't know how much of this you can read, but this was impressive. My mouth sort of gaped. You'll know about the recent president of South Africa, and when Nelson Mandela spent his time in prison, what he looked at every day was the poem Invictus. Invictus was tattooed across the chest wall of my patients. Let me read it to you. Out of the night that covers me, black as the pit from pole to pole, I thank whatever gods may be for my unconquerable soul. In the fell clutch of circumstance, I have not winced nor cried aloud. Under the bludgeonings of chance, my head is bloody, but unbowed. Beyond this place of wrath and tears lies but the horror of the shade, and yet the menace of the years finds and shall find me unafraid. It matters not how straight the gate, how charged with punishments the scroll. I am the master of my fate. I am the captain of my soul. I'm looking at him in pre-op clinic, and I'm going, geez, okay. How does a 25, 28-year-old become CEO of a company successful? Is it the surgical outcomes that have given him that opportunity? Is there some aspect of meaning that has held him together? I don't know. Part of my job is, and part of my job has been, to develop the pathophysiology and the pathophysiologic understanding of how to make people live longer, and in my mind, live better. At the same time, I've come to recognize that that obligation of each of us comes with it, the obligation to be the physician that each of us, or clinician that each of us grew to be when we wanted to go into medicine. And we're in an age, in a real age, and I'm going to sound trite, where the rest of the world sort of caves in on us with our electronic medical records, the 20 to 40% of extra time that we need to spend. And most of us do not have the time to sit there. It's interesting. Studies have been done in palliative care. It takes 6 minutes to get an in-depth assessment of your patient's goals and to try to align our therapies with their goals, as long as we study and understand the art of that communication. Most of us don't. We haven't studied that art. And so what am I going to do? Next year I become a palliative care fellow, age 57, soon to be 58, 28 years in cardiology. I'm going to be a palliative care fellow at my institution. Salary drops considerably. Yes, it does. Thank you. To try to make a statement to my field. Things happen when stakeholders align. In cardiology, with the advent of TAVR, with the advent of ventricular assist, we're at a crossroads, right? Dollars and cents, outcomes, how do we make patients with chronic heart failure become more compliant? How do we decrease rehospitalizations? The hospitals have a goal. Division chiefs have a goal, but so too do patients. We have a captured model of high morbidity and high mortality in care of the adults with congenital heart disease, which is disease over a lifetime. I've argued to the care providers at our humble institution, that Crimson H up north in Boston, that typically has its nose up like this, forgive me, to say that stakeholders align by studying the utility of palliative care at an early phase, not at the end of life, but throughout the early phases of heart failure, to see if we align with patient goals, we can make a difference in compliance, make a difference in rehospitalization rates. And the crazy thing is, they bought in. I don't understand why, but they did. They bought in and they're supporting this. And let me leave to you all this statement. The world sees Houston. It does. It sees Houston. And it has seen what you've done here over the past number of years. You did leave us. You did leave us. And the world sees the legacy of this city for this disease, for mechanical hearts, for heart failure, for all the cardiology and medicine, I must say. As you go about that, I'll share with you my experiences in palliative care. I know that your programs have built this into your systems. I look forward to sharing to you my experience, my journey through that. And hopefully you'll take away something from those patients as much as we do the physiology. Thank you for spending some time with me.
So fantastic talk, Mike. I really appreciate that. I think we have a unique opportunity with a lot of our patients to really develop a really phenomenal bond. Just like some of our family practice and our primary care physicians actually do, because we go through thick and thin with them. But one of the challenges that I always find is that sometimes many of my patients have not transitioned at all, and so they show up to my office dragged by parents, spouses, etc., for something wrong after 20 years of no care whatsoever. And so that very first visit is about defining what's actually happening to the patient. What is the illness? That things weren't cured when they had their TET repair at age 2. So when that happens, I find that there becomes this disconnect of the interaction between myself and the patient and actually creating the bond that we actually have to have in order to develop these relationships and have these conversations. It seems like it's an intrinsic part of what we do as adult congenital heart providers. How do you get around that, and how do you create that 6-minute interaction?
Sure. So great question. Huie's point is in the fell clutch of circumstance. We are typically thrown together with patients in their crises. Crises is a bad time to be having these discussions. How many of you all rotate in the units? How many of you do unit time, ICU time? Vast majority of us, most of us. I had this discussion with our CCU head a year ago and again just recently. Typically in the unit, patients are facing catastrophic illness and we're at odds because we're the person offering the therapies and at the same time have to really get to know a family. We've got multiple support services, each with different views, and that concept of a family meeting or team meeting is a little bit different because we hold the power of making those decisions. And we've argued that perhaps there should be a patient or family ombudsman, somebody who is outside of the direct patient care that leads a family through those critical decisions and understanding what they want outside of the care provision team. It is quite awkward for us to be immediately thrust in that role of care provider and guiding patient in the crisis. I have to say it's doable. It is doable, but for now, I think that, look, most of us, again, skill set we have, we can be more effective and efficient at it. Time we don't have, and truth be told, most of us went into the cardiovascular sciences because of data-driven science, and this is a fuzzy field in many ways. So most of us do not bond with spending that time here. We came to Methodist, we came to surrounding Houston to drive data and to drive greater understanding physiologically. Most of us did in terms of outcomes. I think there has to be a separate team for now in these crisis situations. And then as we get more accustomed to it, then we'll figure out how do we apply that. Do we apply this in each and every one of us, or do we apply this in a team that supports us, just like we have other supportive services? Well, thank you all very much. I appreciate you sitting with me.